Our today's topic is biometry in special situation. Let's start. During biometry, we expect usually the following. We want an eye with axial length not too long or too short. We also want regular corneal curvature with average size, shape and reflective power. Also, normal anatomy of anterior chamber, lower gates of nuclear sclerosis, transparent media, and retina while attached with perfectly normal fovea, and will also expect zero postoperative refractive error. The challenging situations for IOL power calculations. The following factors make IOL power calculation difficult. These are the aphakic eye with silicone oil filled eye, high myopic or hyperopic eye, pediatric eye, media opacity, post-refractive surgery status, scleral buckle, corneal ectasia, biometry for toric IOL, retinal detachment, and edema. Now on to discuss basics of biometry. Components of biometry. Biometry consists of two procedures, keratometry and axial length. Methods of measurement of axial length. We can use it with ultrasonic method that is divided into two subdivisions, applanation and immersion, and on the other hand, axial length measurements can be done by optical method. Here's the picture shows the applanation technique. The probe touches the cornea. Here the cornea, and this is our probe. And here is the scanned print, and we can see the spikes of probe, tip and cornea. Shows A indicates A, and B indicates anterior lens capsule, C indicates posterior lens capsule, D indicates retina, E indicates sclera, and F indicates orbital fat. In the immersion technique, here also shows the spikes of the same, and here is A shows probe tip, B indicates cornea, anterior and posterior surface, C indicates lens capsule, C indicates anterior lens capsule, and D indicates the posterior lens capsule. E indicates retina, F indicates sclera, and G indicates orbital fat. Picture shows a keratometer, manual keratometer, and here is the radius of curvature of anterior cornea. This is anterior cornea, this is the center of curvature, and this is the radius of anterior curvature. Keratometry is used to measure the corneal curvature, and it is done for axial length measurement, and we find K1 and K2 from keratometry. Types of keratometer. There are three types of keratometer: manual keratometer, autokeratometer, and tomography. Optical biometry. It can be divided into partial coherence interferometry, optical low coherence reflectometry Lenstar 900, and swift source optical coherence tomography OCT Master 700 and Tyrion. is a picture of biometry IOL formula. We have two types of formula, theoretical formula and regression formula. And according to generation, we have four generations of IOL calculation formula. Number one, first generation. Here theoretical Winkhorst, regression SRK. Second generation SRK2 and Hofer. Third generation SRK3, Hofer Q and Holiday 1. And fourth generation we get Holiday 2 and Hibis. We also get some newer IOL calculation formulas, and these are Barrett Universal 2 formula, Olsen formula, Hill RBF formula. Now we shall discuss some special situations in biometry. First of all, Afagekai. In the Afagekai, sound travels at uniform speed at a rate of 1532 meter per second. And in the other media, sound waves cornea, sound velocity is 1641 meter per second. Aqueous or vitreous, sound speed is 1532 meter per second. In the crystalline lens, 1550 meter per second. Solid tissue, 1550 meter per second. In the silicone oil, in case of 1000 CST, 980 meter per second. In case of 5000 CST, 1040 meter per second. Two lens spikes are replaced by single spike anterior vitreous face and posterior lens capsule. Immersion technique, optical biometer are the methods of choice. In anterochamberal intraocular lens, sulcus or sulcus fixation IOL, appropriate a constant is used. Pseudophakic IOL exchange. Eyes with IOL have an extremely high spike at the lens followed by an artificial chain of reduplication echoes which can be confused with the retinal spike. You can see here the long spikes. Silicone oil filled eye. Sound travels slower through silicone oil. This low sound velocity makes axial length becomes erroneously long. Difficulty of measuring axial length can overcome by increasing the system gain. Refractive index of the silicone oil is higher vitreous. Silicone filled eye. Continue. Ultrasonic measurement and optical measurement. In case of ultrasonic measurement, axial length in sitting position, application of correction factors, and in optical measurement, silicone filled eye mode should be selected. In case of mediapositis or dense cataract, here issues are strong sound attenuation can significantly impair the ability to display spikes from the various interfaces. Ultrasound biometry is superior to optical biometry. B-scan may be needed in vitreous hemorrhages and asteroid hyalosis. What to do? Maximum gain gating may be required to obtain spikes of sufficient height from the posterior lens capsule and retina. B scan is done and correlated with A scan in mediopacity. Here we see the A scan and below the B scan picture. A scan we see some spikes like A, P, and the spikes. And here we can see uh, opacity. Scleral buckle. We see the scleral buckle in the picture. Scleral buckle increase axial length by 0.7 to 0.9 mm with small shallowing of the anterior chamber depth. And what can we do? IUL power calculated has to be reduced by 0.50 to 1 diopter. Another issue is high myopia. Here issues are low scleral rigidity, posterior staphyloma, axial measurement is critical. Ultrasonic measurement in posterior staphyloma give a refractive surprise. We can see the irregular shape of the eyeball due to posterior staphyloma. In case of high myopia, we get erroneous axial length, and here is the true axial length. Due to posterior staphyloma, we get an extra amount of axial length. What can we do? For uh, overcome this issue, immersion or optical biometry is the options. Probe with fixation target can be used. B-scan should be done. High myopia. Continued. Our formula needs to be chosen accordingly. Preferable formulas are Barrett 2, Hill RBF, and Kane. Surgeon should aim for minus 0.50 diopter to 1 minus 1 diopter post-operative refraction, as most elderly will prefer being nearsighted. High hypermetropia. Here issues are short axial length, relative short ocular dimensions, shallow anterior chamber, increased IOL power sensitivity to small error. And the solutions are immersion optical biometry technique of choice, Hoffer-2 formula, Haigis or Barrett universal 2 formula. Piggyback IOL. Here we can see the shape of piggyback IOL. Primary piggyback IOL, very high hypermetropic eye, and secondary piggyback IOL, correction of residual refractive error in pseudophakia. In case of pediatric eye, the challenges are shorter axial length, steeper cornea with higher keratometry value, and smaller anterior chamber depth. Here are some axial length with IOL power. If axial length is 17, IOL power becomes 25 diopter. Axial length 18, IOL power 24 diopter. Axial length 19 millimeter, and IOL power becomes 23 diopter. Axial length 20 millimeter, and IOL power becomes 21 diopter. For pediatric biometry, there is no formula proven to have an advantage over others. Holiday 2, Hoffer Q, and Barrett Universal 2 may be recommended for pediatric IOL power for calculation. 20% undercorrection if the child is less than age 2 years. 15% undercorrection for age 2 to 5 years, and 10% undercorrection for age 5 to 8 years should be maintained. Both eyes must be measured. Now we can discuss special situations with cornea. Challenges are changes in K reading alters the IOL power in a ratio of nearly 1:1. The special situations are refractive surgeries, keratoconus, corneal scar, corneal transplant, or triple procedure. Biometry in post-refractive case. Here we see the stiff cornea and after ablation a flat cornea. Basic concepts of refractive surgeries. Ablative keratorefractive surgery flattens anterior corneal radius but leaves posterior corneal radius mostly unchanged. You can see posterior radius of the cornea unchanged, posterior part unchanged, but the anterior cornea here flattens. The true corneal power following photorefractive keratectomy and LASIK laser in situ keratomiliosis is difficult to measure by keratometry or corneal topography. Biometry in post-refractive cases, contribution of IOL power errors, inaccurate measurement or calculation of corneal power, incorrect estimation of effective lens position, myopiclassic underestimation of the IOL power, and hyperpiclassic overestimation of the IOL power. Biometry in post-refractive cases, preferable methods are clinical history method, Barrett through K with or no history, corneal bypass method, Masket formula. Post-keratorefractive online calculators. SCRS post-keratorefractive online calculator for myopic, LASIK, hyperpic LASIK, and prior radial keratometry. Keratoconus. Using keratometry reading of such eyes will yield an overestimated reading due to effective lens position calculation error. Formulas which consider only axial length and not keratometry to calculate effective lens position gives better prediction of true IOL power. Barrett universal formula best in eyes with mild to moderate keratoconus. Haigis is accurate for advanced keratoconus eyes. Other appropriate formula for long eyes can also be used. Corneal scar. Fault effective lens position estimation. Ultrasound biometry is better. Reading of the other eye. Formula using only axial length and anterior chamber depth. That is Hoffer-Q and Haigis. Corneal transplantation. We see here the transplanted cornea with a round demarcated area. If a triple procedure is planned, it is suggested that readings of other eye be used. An alternative option is to use the average readings from a series of previous transplants. Biometry for toric IOL. Commonly used calculations are Barrett toric calculator, Holiday IOL consultant toric planner, and Assort calculator. We see the Barrett toric calculator. Here is the input and we get the output. Retinal detachment and edema. Axial length measurement using immersion type ultrasound biometry is superior to optical biometry. The axial length should be measured during both an immersion scan ultrasound and optical biometer in cases of retinal detachment. If the axial length results from both techniques don't correlate, the method used to determine IOL power selection should be carefully considered. Opposite eye biometry reading can be taken. Take home message: owl power has to be calculated more precisely. Meticulous and careful biometry can give a satisfactory outcome to both patient and surgeon. With modern technologies and updated formula, owl power calculation is becoming easy and more accurate. So we should also keep up to date. Thank you for watching. Keep in good health.